Hey everyone, welcome to This Explainer. Today, I'm stepping in as your personal medical tutor, and we are going to completely master the orbital blowout fracture. My goal here isn't just to hand you a boring list of facts to memorize. No way. We're going to build this whole topic from first principles. So by the end of this session, you'll deeply understand the anatomy, the clinical signs, and those really tricky high-yield exam traps. You're going to absolutely crush this topic on the wards, your MBS, and your USMLE Step 1 board exams. Let's get into it. Here is our roadmap for today. We'll be hitting big picture orbital anatomy, the pressure valve mechanism, clinical signs and symptoms, diagnosis and the teardrop sign, treatment guidelines, and finally a high-yield exam review. All right, let's dive right into Section 1, Big Picture Orbital Anatomy. Okay, to really grasp the orbit, I want you to use the Feynman technique with me. Imagine the orbit as a solid, bony box that's holding a very delicate water balloon. That's your eyeball. Now, notice how the roof and the lateral walls of this bony box are incredibly thick and sturdy. They can definitely take a hit. But the floor of this box, which is made up of the zygomatic, palatine, and specifically the maxillary bone, is shockingly thin. It is basically a really weak floorboard.
So, you always have to ask, why does this actually matter in the clinic? Well, right beneath that super thin orbital floor is the maxillary sinus, which is just a big empty space filled with air. This means your orbital floor is quite literally the roof of the maxillary sinus. If that thin floorboard breaks, gravity takes over, and everything inside the orbit is just going to prolapse or spill downward right into that empty sinus below.
Moving on to Section 2, the pressure valve mechanism.
So let's talk physics. How does this injury actually happen?
A blowout fracture usually goes down when a blunt object that's larger than the orbital opening, so something bigger than 5 centimeters, like a fist or maybe a tennis ball, strikes the eye directly. Because the object is too big to enter the bony box itself, the eyeball absorbs the blow. But thankfully, the eyeball doesn't pop. Instead, it gets shoved backwards, acting almost like a hydraulic battering ram. The pressure inside the orbit massively spikes. Since the walls and the roof are completely solid, that pressure desperately needs somewhere to go, so it finds the weakest link, our thin floorboard. The floor snaps, acting exactly like a pressure release valve, and all those orbital tissues prolapse downward. All right, Section 3, Clinical Signs and Symptoms. Now this is where it gets super interesting. We can perfectly connect the external symptoms you see at the bedside to the internal pathology. When a patient tries to look up, but the affected eye is completely stuck, it causes vertical diplopia, or double vision. Why does that happen? Well, imaging shows us exactly why. When that floor snapped open and then shifted, the inferior rectus muscle, which sits at the bottom of the eye, literally fell into the crack and got physically trapped in the fractured bone. It's anchored down, so the eye physically cannot look up. Another absolutely massive clinical clue is infraorbital nerve anesthesia. The patient is going to tell you that their cheek, their upper lip, and honestly, even their upper teeth feel totally numb. Now, why their teeth? That seems weird, right? Well, it's because the infraorbital canal runs directly through that fractured maxillary bone. When the bone breaks, the nerve living right inside it gets damaged, entirely cutting off sensation to the midface and those upper gums. Okay, so your patient has double vision after trauma. You have to play detective here. Is the muscle physically trapped in the bone, or is the orbit just temporarily swollen with fluid that's limiting movement? To figure this out, we do something called the forced duction test. We numb the eye, gently grab the tissue with forceps, and try to physically move the globe ourselves. If it simply won't budge, that muscle is mechanically entrapped. If we can move it, then it's just orbital edema, and you know it's going to improve as the swelling goes down. You also want to watch out for an ophthalmos, which is just a fancy term for a sunken eyeball. Because the orbital floor dropped, the orbital volume has essentially increased. So the eye sinks backwards and downwards into that newly created space. But here's a huge trick for the wards. You usually won't see this on day 1. Yes, the eye sinks, but the severe acute tissue swelling pushes it right back forward. You're really only going to notice that in ophthalmos days later, once the initial edema has completely resolved. Section 4, Diagnosis and the teardrop sign. First things first, look closely at your patient. You'll obviously see severe periocular ecchymosis, heavy bruising and swelling. But if you palpate the skin, you might actually feel a weird crackling sensation. We call that subcutaneous emphysema. It happens because air from the maxillary sinus has been forcefully pushed up into the orbital tissues. This is exactly why you must explicitly instruct your patient, absolutely do not blow your nose.
Blowing the nose dramatically increases sinus pressure, which forces even more air and potentially infected mucus straight up into the orbit. Oh, and when you get a CT scan, you'll see the classic teardrop sign. It's a literal teardrop-shaped mass of fat and muscle just hanging down into the maxillary sinus.
Next up, Section 5, Treatment and Surgical Guidelines.
The decision tree here is pretty straightforward. For small cracks where there is absolutely no muscle entrapment, we manage it conservatively. That means ice packs, oral antibiotics, nasal decongestants, and again, strictly no nose blowing. However, we definitely operate and repair the floor, usually within about 2 weeks, if there's mechanical muscle entrapment, an unacceptable anaphthomos of greater than 2 millimeters, or if they have persistent double vision in their primary gaze.
Okay, guys, listen up, because this is a massive, high-yield exam trap, the white-eyed blowout fracture. This specific fracture happens in children and young adults under 18. Because pediatric bones are incredibly elastic, the floor snaps open from the trauma, the muscle drops in, and then the bone immediately snaps shut again. It acts exactly like a trapdoor. So externally, the eye looks totally white and completely normal. There's no massive bruising. But internally, that trapped muscle is being strangled, which triggers the oculocardiac reflex. The child will present with severe, acute nausea, vomiting, and bradycardia. Make no mistake, this is an absolute urgent surgical emergency to save that muscle from necrosis. Finally, Section 6, High-Yield Exam Review. Let's test that active recall.
Let's do a classic board-style question. A 14-year-old gets hit by a baseball. He has absolutely no external bruising, but he presents with severe nausea, vomiting, and he cannot look up. What is the diagnosis? Take just a second to think about the physiological mechanism we just covered.
All right, if you said white-eyed whiteout fracture, absolutely nail on the head. Awesome job. Because he's 14, his elastic bones created that trapdoor effect we just talked about. And remember, the severe nausea and vomiting aren't from a concussion, they're actually the vagal response, the oculocardiac reflex triggered by that strangled inferior rectus muscle. This requires urgent surgical repair.
Let's do one more to really integrate this stuff. A patient comes in with restricted upgaze and totally numb upper gums. Which exact bone is fractured? Lock your answer in. Got it? It's the maxillary bone. This is basically the ultimate integration question because it perfectly combines the structural failure, knowing that the maxillary bone is the weakest part of the orbital floor, with the neurological symptom. The infraorbital nerve runs directly through it, supplying sensations straight to those upper gums. To wrap things up today, I want to leave you with a bit of a provocative thought to prime your brain for your next study session. We established that the orbital floor acts as a pressure release valve when the eye gets struck. But what happens if the trauma is incredibly severe and those bones just don't break? Where does all that massive pressure spike go? Well, it crushes the optic nerve, leading to orbital compartment syndrome. And that is a fascinating topic for our next explainer. Keep studying those first principles, stay curious, and I'll catch you in the next one.